name is Dr. Farzan Bahin from the Department of Gastroenterology and Hepatology at Westmead Hospital. And I'll be presenting the article Comparison of the Histopathological Effects of Two Electrosurgical Currents in an in vivo porcine model of esophageal endoscopic mucosal resection, with my co-authors being Dr. Nicholas Burgess, Dr. Kabir, Dr. Subramanian, McLeod, Dr. Mahajan, Maria Pellise, Rebecca Sonson, and Professor Michael Bourke as being the senior author. It's well established that endoscopic resection in the upper tract, particularly in the esophagus, for early neoplasia, be it squamous or adeno with Barrett's, is safe and effective. And tissue resection in general should be the gold standard for any treatment of gastrointestinal neoplasia. The main drawback of endoscopic resection in the esophagus is that of stricture formation, which can be quite symptomatic, affect patients' lifestyle and nutrition, and add to the surveillance and dilatation burden following the procedure. In addition, it may mean that the tolerability as a procedure to patients and both doctors is reduced. Separate to this, the histopathological correlates of the endosurgical currents that are currently used in both the upper and lower gastrointestinal tract are not very well known. There's a wide variation in practice patterns, and the gold standard of what type of electrosurgical current to use for which lesion and which tract is currently not well defined. Bearing in mind that the majority of therapeutic endoscopy related complications occur due to diathermy. So when thinking about these things together, our group pondered whether the type of electrosurgical current actually does make a difference to the formation of strictures following endoscopic resection. I refer to the article to several electrophysiological principles which are imperative to the understanding of the different types of electrosurgical currents. And in brief, as the amount of coagulation and carbonization increases, the heat in the tissues is increased, and therefore the relative risk of transmural injury and subsequent scarring possibly may be increased. In general, there are two main types of electrosurgical currents that are available in clinical practice. One is the low power coagulation current, also known as LPCC, where the voltage is not limited. The power is fixed, and therefore voltage may vary quite a bit. It can overcome very high impedances and theoretically result in significant transmural injury. And the other broad type is the microprocessor-controlled current, which is voltage limited. It can sense tissue resistance and adapt its rate of power output depending on the impedance that it encounters. So given that the optimal electrosurgical modality for endoscopic resection in the esophagus is not known, we aim to undertake a study that could possibly answer this question. The current literature is mainly looking at low power coagulation current. A lot of the trials of endoscopic resection are based on that, and we just wanted to see whether microprocessor-controlled current may have more favorable histopathological correlates. And the way we designed the study was to perform a porcine study, because such a study is very difficult to perform in humans, and evaluate the depth of thermal injury that happens following either microprocessor-controlled current or low power coagulation current. The hypothesis was that microprocessor-controlled current results in less depth of esophageal injury. So we got approval from the Animal Ethics Committee to perform an in vivo animal study in porcine pigs. We performed a very similar procedure in the pigs with endoscopic band mucosectomy in a standard fashion. The resections were randomized 1-to-1 within the same peak to either microprocessor-controlled current or low-power processor-controlled current with a single operator and a standardized technique. After 72 hours, the animals were sacrificed and a histological assessment was performed of their esophagus. And the key features that we looked at were the degree of ulceration and necrosis, as well as inflammation that extended to the various layers of the esophagus, from the mucosa, submucosa, the muscularis, and down to the adventitia. We also quantified the maximal depth of thermal injury between those two modalities. So, in terms of the main results that we found, there was a significant difference in 45 resections in total between the microprocessor-controlled current and the low-power coagulation current, with the baseline characteristics of the resections and thickness of the lesions being the same. So the key findings from our study were that the degree of ulceration that extended to the muscularis propria, as well as the degree of necrosis that extended to the muscularis propria, occurred in only 1 out of 21 resected specimens, compared to 9 and 13 out of 24 respectively in the low power coagulation group, which was statistically significant. Similarly, the mean quantified depth of the injury was greater with the low power coagulation current compared to microprocessor controlled current. In addition, we also looked at 10 human esophagectomy specimens where we looked at the normal areas unaffected by the underlying pathology to compare the thickness of a porcine and human model, and there the relative thickness in the human esophagus with respect to particularly the submucosa and the muscularis propria was greater. So I think that's important to bear in mind. In summary, the study showed that in a porcine in vivo survival model, the depth of thermal injury as evidenced by ulceration and necrosis was significantly greater in the low power coagulation current compared to a microprocessor controlled current. And this may also affect the rate of subsequent stricture formation, because it is hypothesized that the degree of fibrosis and stricture formation is proportional to the amount of inflammation and injury that's caused. So we proposed that in the upper esophageal tract, endoscopic resection, particularly in the esophagus, which is tubular and non-compliant, should be performed with a modern microprocessor-controlled current as the standard of care, with the theoretical benefit of reduced histological depth of injury and possibly also reduced stenosis rates. It is very difficult to prove such a concept in humans because you would need to perform a esophagectomy study to definitely prove the point, and therefore a esophageal model was the closest that we could have. And certainly this area of post-endoscopic resection stricture formation is very topical. There's a lot of information that we still need to determine, and I think a study like that is quite an interesting finding that may affect clinical practice. Thank you very much.